Let's get started. We still have some people coming in. I suspect some people logged in online, which is what I usually do. So I will, having been on that end of things, I will be cognizant of you, and hopefully we'll have time for questions at the end, and we'll try to entertain some of those from the outside audience if we can as well. For those of you who don't know me, I'm Bud Wiederman. I'm one of the infectious disease attendings here. And today I'm giving, I guess, what is a somewhat unusual talk for me, and I'm massively outnumbered by lawyers in this presentation. But this is actually a topic that's both interested and concerned me my entire career. Struggled to come to terms with how to do the subject of curbside consultations correctly. The genesis of this grand rounds probably really started with a joint morbidity and mortality conference that infectious disease had with rheumatology here. It's about a year and a half ago. And if you believe the literature, and some of this I think suffers from confirmation bias, but if you believe it, pediatric infectious diseases and pediatric rheumatology are the two most curbsided specialties in the country. And I feel that most days. But I think we called that M&M conference for a specific case. We're actually not going to discuss that one because it was so involved. It involved communication with an outside pediatrician, weeks after the communication happened. So there doesn't lend itself well. There's a lot of murkiness to it. But we have plenty of other examples to you. Joining me today are Rebecca Cady, who most of you know is our Vice President and Chief Risk Officer here. Adam Smith is a partner at Blankenship and Keith, and he actually did some conference here. We can't figure out when it was, several years ago. I kept his handout and I still have it for I don't know how many years ago, on the subject of curbside. I'm very pleased he could come. And then we also have with us Annetta Nikolic, who's also from Blankenship and Keith, and we'll be talking about a few of the cases that owe her a great deal of thanks for sort of digging through various cases that apply to curbside and sifting through some of them, extracting them for our purposes. And we're not conflicted. So first, let's start with the definition. And there are all kinds of definitions out there, but this is, I think, the most accurate for our purposes. The curbside consultation is an informal process whereby a physician obtains information or advice from another physician to assist in the management of a particular patient. But the consultant neither reviews the patient record nor examines the patient and does not document his or her recommendation. So that, for the purposes of today's discussion, that's our definition of curbside. So let me share an email with you, and I get curbsides, I don't even know how many a day, email, text, phone call, stopped in the hall, whatever, comes from all places, but this is a representative one. This is from a neonatal nurse practitioner at a community neonatal intensive care unit, and she occasionally asks me questions, and here she has a newborn, day of life 18, came in with mastitis, blood culture's negative, no local drainage to culture, breast was red and firm, it's improved, but still significant in duration, received 4 days of clindamycin, day 6 of vancomycin. Do you have any thoughts on the length of treatment? Is 7 days adequate, or treat till the tissue normalizes? Any of you are all experts in infectious disease and neonatal mastitis. What would you tell this person? Don't be shy. Dr. Sandler says yes. Consult surgery. Consult surgery. Dr. Barami from neonatology says he would just refer to IU. Well, we'll keep this case in mind. We're going to come back to that at the end, because this is, for me, an example where I feel pretty frustrated that I can't give good advice over the phone, no matter how hard I try. Yeah, so for the people online, the comment from the audience was, from the endocrinologic perspective, how do we know the accuracy of the information we're getting? And we'll actually touch on that. So I did not plan to say that. So we'll go through a little bit of the literature, not to bore you too much, and we're starting out with some pretty old stuff. This is from an editorial in JAMA written by an internist from Northwestern University. From the point of view of the requester, Curbside, there are a lot of pros. It's more efficient than doing your own literature search. It doesn't cost anything. It maybe minimizes the number of people crowding around the patient, and might even be educational. Helps you learn new things. The cons are just what was mentioned. There's this sort of implicit bias in how the requester frames the case. Because we all, we're all on both sides of the spectrum of the curbside. Before we're calling to ask a question, we have made some judgment, and we may be skewed in how we collect data at that point and present it, especially. And the con may also be if the person requesting the advice hears something really screwy, they may not feel comfortable challenging that information. Maybe the screwy advice was because the consultant didn't quite understand what was going on. So there are areas to slip up. From the consultant perspective, it's efficient. If we're salaried, which I am, doesn't really cost me anything. It might be intellectually stimulating. Okay. Yes, my salary has just taken a dive for the next fiscal year. It maintains relationships with providers, so that's a stream of formal consults in the future and also educational. But again, on the con side, it's the same implicit bias. So, I might suspect, this is a call coming from a neonatologist. They don't know anything about neonatal mastitis. So I can't believe any of this. I'm not going to talk. And I would never say that. But, yeah. Oh, right, yes. It's not on the U.S. News Survey, thankfully. And the cons are, as we said, just giving the wrong advice, and that's really the worst thing. And then location, location, location. This isn't real estate. But whoever's on the receiving end, I don't know, if I played golf, I might be on the golf course. I'm in the middle of patient care or patient conference, something going on, and sort of out of all this, I'm extracted and have to refocus. And that's also a chance for me to make an error as the consultant. So it's risky from a few points. A little bit more in the literature, this was a study performed by neurosurgeons in the United Kingdom, in Nottingham. And apparently they get phone calls for advice all the time. It's a little scary to do a curbside of a neurosurgeon. I don't know, maybe not. But it turns out, so they went back and looked, and they keep cards on all their phone calls, but they're also part of an integrated system, so they can go into the patient's medical record and actually see what happened, what developed. So they did this in a 10% sampling from a 12-month period, and I've just listed a few things here, like one of the concerning things to me, the Glasgow coma score that the neurosurgeon on the phone wrote down was very different from the true Glasgow coma score. And those clinicians out there, you know that being off by 10 points on the Glasgow coma scale is incredible. So it's just very concerning. They also got second calls about the same patients, which they felt in large part were due to a new provider coming on and not getting the information that the neurosurgeon had already told the previous provider. Certainly, probably all of us have experienced that here. Interestingly, they kept track of the grade of the referring doctor, level of training. There was no correlation with how poor it was. This is another study of adult patients, curbside consultations from primary care providers to academic specialists. And again, they were keeping records of these curbside questions, and then they retrospectively analyzed them, so maybe lost a little bit in translation. But they chose to analyze these by a PICO format, for those of you familiar with evidence-based medicine and how to formulate a good question. But what they found was how well the question was framed was predictive of the quality of curbside and whether a consult was provided. So, talking about intervention and outcome. So intervention meaning a treatment or maybe a diagnostic test. The outcome is, will the patient be febrile fewer days or die or not die, things like that. So if on the right-hand or left-hand side of the table there, if the question that was asked didn't include anything specific about the intervention or outcome, the result of the curbside was usually unsatisfactory. It was a little more likely to result in the consultant requesting that they formally consult. Whereas if both of those items in the question were specified, the curbside, they felt, was a little more effective in terms of less non-definitive outcomes, which you can see in the lower right there. There are other things, sort of maybe self-fulfilling prophecies, but adult ID academic practice, this was Fletcher Allen Healthcare, University of Vermont, decided to keep track of their curbsides for a year, 1,000 curbsides, and then they went back and scored all these, and they decided 78% could be billed at CPT level 4 or 5. They looked at weighted relative value units. It's 17% of the clinical work time for this infectious disease group, and would have been in 2004 or $5, $93,000 billable revenue was billed. So that's my reason to ask David for a raise. But then, for me anyway, the scales started to tip with some more recent study. Giving bad advice. So this is prospective cohort, sort of a convenience sample where the routine was for curbside consults, the consultant would always request a formal consult. That was their practice. But they also took information. So they collected, it was sort of a convenience sample, 47 cases where they did the curbside, but then also saw the patient. And this just gives you an idea, and long story short, if they felt they were getting inaccurate or incomplete information when they actually saw the patient compared to what they heard, the advice in some instances changed dramatically, in significant proportion. Not surprising, but at least documented. And then specifically with infectious diseases, this was rather striking. Retrospective chart review, 90-day telephone follow-up in a hospital system in Finland of a little over 300 Staph aureus bacteremia episodes in adults. And they looked at a number of outcomes, and just the red there are the statistically significant issues. So if you just do a curbside or no consult in these episodes of Staph aureus bacteremia, compared to a formal consult, the 90-day mortality is significantly higher in curbside and or no consult. If a formal consult was done, a deep infection was more likely to be identified, and also the time to afebrility was shorter in that formal consult group. And at this point, with that little taste of the literature such as it is, I'm going to turn it over for a time to the legal folks, and I'd like to ask Becky Katie to come up and just pose some questions for her and talk about some of our internal experience with Curbside. Okay.
Thank you. So far we've been lucky, and I'll knock wood. We have not been pulled into cases involving other providers where we have been the curbside consultant. So in other words, in a case where somebody from another hospital calls one of our doctors, gets a curbside, either does or doesn't follow their recommendations, something bad happens to the patient, that outside doctor gets sued. We have not been dragged into one of those cases to date. So that's good news, right? But I can say that with respect to our internal curbside, so where somebody in the ER calls and talks to a cardiology person, or somebody on the HKU talks to a GI person, or whatever, all these different iterations you could think of, those instances have kind of raised problems in our defense of cases where we are the defendant. And where this usually comes into play is where whatever the unit is that's got primary responsibility for the patient has an informal consultation with another service about something that seems to be going on with the patient, right? And whatever the outcome is of that conversation gets documented in the patient's record by the person speaking, the consultant, to is often, in the instances where it's caused a problem, it's been a trainee-to-trainee communication. So a resident on the unit calls a resident from the specialty service, or sometimes a fellow, but it's oftentimes a trainee-to-trainee kind of a curbside, which might be the subject of its own grand rounds, because I think it poses separate risk issues. But in those instances, there is often, if that particular piece of kind of decision-making and advice-seeking often becomes an issue in the case as to whether we as an organization appropriately managed the patient's sort of difficulties that led to that consultation. And the main issue that we found is that there's often a discrepancy. So there's some documentation by the person who speaks out the curbside. And that's often not super clear in terms of what information was imparted to the specialist, what the specialist's specific recommendations were. And when those people are deposed, there's often conflicting information. So the person seeking the consult says, yes, I called, I talked to the cardiology person, I told them X, they told me Y. And the cardiology person, if they even remember that the encounter happened, has a different perspective on, well, no, they didn't tell me this, they left out this one really important piece of information. If I had known that, I might have told them something else. So that's where we have seen this really kind of come around to cause difficulty for us in defending cases. That we've managed those situations, but that's where we've seen it come up. And it often involves a trainee-to-trainee interaction where one trainee is getting advice from another trainee in another service. So in terms of balancing the legal risk, I know that Dr. Wessel's team is working on kind of a formalized system for the outside consultants coming in. We had a vendor demonstration recently for this vendor that actually provides a platform where you can try to monetize this. So I think that the aspect of the fact that we may be leaving revenue dollars on the table, at least from the outside standpoint, I don't know about internally whether it would make a difference if we formally billed for those or not. I don't see anybody from revenue cycle in the room, but that's something we should look at. I think there are benefits to a certain level of interaction with outside folks, in that we know that consults and formal consults and transferring patients tends to be a relationship based. If they're confident that they can call Children's and get bits of advice on lower level things that are low risk, then they're going to be more inclined to send us patients when they know that it's something they can't handle. So from a legal standpoint, I don't think I would ever take the position that, gee, we should just never do this. But I think we can talk about, and we will here in a few minutes, how do we do this in a way that's going to minimize the risk to our docs as individuals and to the organization in general? And most importantly, how are we going to make sure that the curbside doesn't kind of enable bad care on the outside, right? Because that's, I think, got to be part of the thinking as well. So any questions on the kind of pure legal stuff? Yeah. It's definitely, yep. Mm-hmm.
And, there's some chart.
No.
There's a curbside that goes some.
Right. Exactly.
So I'm not exactly sure American, but a curbside, but what if you can't take manager stuff, trying to help them.
Exactly. So I think in terms of the outside curbside, we are not recommending that you document that. I mean, if it's going to be informal, then it should stay informal, and it should be, the conversation should be around, hey, I'm basing this on what you're telling me, so I'm totally reliant on that, and try to kind of couch the advice in terms of, well, in general, with a patient that has X and Y and Z that you just told me about, and just based on those three factors, we would approach it this way. But clearly, if you don't have enough information to be able to give any kind of meaningful advice in an informal way, then it would be I would urge you to try to get it more into the formal space where we really need to see this patient in order to be able to help you. I really don't think we should be documenting curbsides when we're talking to outside people.
Becky, I do have a question because the curbsides have changed significantly over the past decade. The curbsides aren't a phone call anymore.
They're an
emails.
Yeah.
And in the emails, if you're going to try to be that helper, you are documenting what your opinion is.
Yeah.
You can couch it to some degree.
Yeah.
You can't spend 15 minutes putting in every disclaimer
No.
before we do it. So how does it ratchet up as we put these into emails? No one calls anymore. They email first.
I think that's a great point, and I mean, you're creating documentary evidence of what you said to the person, which on the one hand can be good because in case there's if they try to sort of take what you said and change it, then at least you've got some evidence of what you told them. When I'm talking about documentation, I'm talking about formal documentation, which would be in my mind for an outside where you write them a formal letter saying this is a formal memorialization of of this consult that you requested of me. I certainly don't think that's a good idea unless we're really doing a full-on consult that we're getting paid for. I think email does make it tricky, but I don't think that moves you into that you're officially documenting it. If they approach you via an email, I mean, I suppose you could pick up the phone and leave them a voicemail, but that's not going to be efficient for you. So I don't, I certainly wouldn't take the position that you shouldn't respond via email. I'm happy to help you help craft a standard paragraph that you could just copy and paste into those responses if you want that has some disclaimer language in it. But I think the more you go down that pathway, the more it starts to look like something formal, which increases the risk, in my mind, at any rate. So yeah, no easy answers here for sure.
And those questions are actually a great segue to Adam and Annetta telling us with some actual cases that rose to the surface of the legal system to give some ways. And after they discuss these cases, I'll come back and tell you a little bit about what we've done in infectious disease, craft our own guidelines for curbsides. I will say there are extra cases that we also have, and we're going to post that online after the talk, so if anybody wants to read through additional cases, that will be available.
We don't have time to go through all the cases. We tried to pick a few of them out of this outline to talk about. And I'm going to talk about cases where court said there wasn't a duty of care owed, and then Annetta's going to talk about cases where there was at least some issue about whether a duty of care was owed. So when I talk about duty of care, just to orient everybody to understand what this means from your perspective, legal perspective. In any kind of malpractice case, you first have to establish, if you're going to try to prove liability, that the defendant, the doctor, owed a duty of care to the patient. If you can't get that, then you can't prove anything beyond that, like negligence or whether the actions caused injury or damages were. So the duty of care is then the focus of these types of opinions. And basically what that means is that the court is looking and examining the relationship between the consulting physician and the patient to decide whether or not that consulting doctor was sufficiently involved enough to create that sort of consensual relationship between doctor and patient that gives rise to an obligation to exercise reasonable care in their conduct. And so, and sometimes the courts have looked at these issues and decide, the nexus wasn't really strong enough to say that this doctor was really the patient's doctor, and therefore they're not really going to be able to be held responsible for failing to exercise reasonable care in whatever they did with regard to the consult. And so these cases tend to be decided on a case-by-case basis, and the courts examine the facts of what happened very carefully. And there are a lot of cases, because practice of medicine is quite varied, and therefore the factual circumstances of the cases tend to be quite varied as well. So in a lot of different contexts. So one of the first cases I wanted to talk about was this newborn versus United States case. I think it kind of illustrates some of the general things that courts examine when trying to decide whether or not there was enough connection between the consultant doctor and the patient to say that they could be held liable for something. So in this case, involved an infant who was actually at a hospital in Germany. The baby had been diagnosed with sickle cell disease and had two hospitalizations fairly close in time. And during those two different hospitalizations, the physician in Germany was reaching out to a physician at Walter Reed for advice on how to manage the patient. And some of the communications were by email, and then there were some phone calls as well. The ultimate point of the case factually that led to the claim of liability involved this paragraph at the bottom. While the patient was hospitalized for abdominal pain, the requesting doctor spoke to the consulting doctor by phone about managing the pain, and the consultant doctor recommended a Motrin PCA pump, and then a transfusion if the pain did improve. The consulting doctor asked the doctor in Germany about oxygen saturation, was told there wasn't any evidence of lung disease on the exam, and the child was good. Unfortunately, the child wasn't good and passed away shortly thereafter. So the lawsuit against the doctor of Walter Reed alleged that she had negligently recommended the PCA pump instead of an immediate transfusion and didn't account properly for the oxygen saturations. So the court examined all these facts very carefully and decided that in this circumstance, there wasn't really a sufficient relationship between the patient and the consulting doctor to impose a duty of care. And they examined how frequently and how substantial the phone calls and emails were. And the court sort of articulated this standard. Substantial or frequent consultation amounts to virtual supervision of the patient's treatment, tends to give rise to a duty, whereas informal or occasional consultation does not. And having looked at all the facts of the case, the court said that the consulting doctor's involvement fell somewhere close to the informal advice end of the spectrum. She did not give the type of extensive and continuous consultation that would make her practically the ultimate decision maker in the patient's treatment. The court noted that the physician in Germany retained control over the patient's treatment and did not look to the consulting doctor for supervision. So the focus of the malpractice claim plaintiff's lawyers latched onto was when the requesting doctor testified that if the doctor at Walter Reed had recommended a transfusion, then he would have ordered it. But the court said that this uncertainty by the requesting physician or willingness to accept a suggestion did not impose a duty on the consulting doctor at Walter Reed to decide whether and when to order a transfusion of the patient. And the court said that if that were alone sufficient to impose liability on the consulting doctor, it would discourage curbside consults and lead to disturbing public policy considerations. So that's the first case I want to talk about. And then I want to skip over this Gilbert case and talk about the Sterling versus Johns Hopkins case. This was a case in Maryland, obviously, and the patient was a pregnant lady who developed indications of preeclampsia and HELLP syndrome. The hospital where she was when this was diagnosed did not have a NICU. And so the doctor there was worried that if the baby was born prematurely, there would not be a place for the baby to be admitted for care. So they called the referral service for the University of Maryland, which led to the phone call with, we just called him Dr. K at Johns Hopkins. He was a fellow. But they talked about transferring the patient. And the focus of the case was how the patient should be transferred. In other words, was the patient's condition severe enough that a helicopter ride was required versus just an ambulance, which would take longer. And the case indicated there was some kind of a policy in place that if the patient was on a mag sulfate drip, they couldn't go by helicopter. And in the end, the lady went by ambulance and actually died in that process. So the court held that a summary judgment, meaning that you get out of the case before you even have to go to a trial, was properly granted on the ground that the fellow did not have the physician-patient relationship with the patient. And again, the court articulates general standards about when liability is going to be imposed on a physician, talk about having this physician-patient relationship either expressed, meaning it's explicit, or it's implied that the doctor is going to treat the patient with appropriate skill and care. And the court said that the voluntary acceptance of a physician-patient relationship by the parties creates this presumption of a contractual relationship between them. And in this case, the court held that the evidence wasn't sufficient to establish that relationship for several reasons. First of all, the primary doctor at the referring hospital where the patient was able to look at the patient's deteriorating condition. And that doctor also agreed that he had the final say in whether or not the patient was going to be transferred to town. The doctor at Johns Hopkins, the fellow, did not have any contractual relationship with the hospital where the patient was that would have imposed some kind of duty on him to take responsibility for the patient. And then while the fellow concluded that the diagnosis of the patient with preeclampsia and HELLP syndrome was appropriate, he didn't really give any advice that caused the requesting doctor to rely on his expertise, but essentially conveyed the fact that Hopkins had the facilities and staff to treat the patient which he was transferred. So the court noted that the fellow's actions were not binding on the doctor who had the patient, and just didn't have the level of control, I think, basically, over what would happen to the patient to create that kind of duty. So time's short, so I'm going to turn the podium over to Annette, and she'll talk about a few cases where the court found that there was sufficient evidence to create a duty of care.
Good morning. So as Adam mentioned, I'm going to skip over these next few cases and talk about where the court said there could be a duty of care found. And just very briefly, as Adam mentioned, sometimes these cases get dismissed at the outset because the court just said there isn't enough. In these cases, the court looked at all the circumstances and said, basically, there's enough to go to a jury to decide whether there was a duty of care. So it's possible a jury could find there was not, but in these cases, the court said it could at least go forward and that they did not want to dismiss it early. So the Jacobs case is out of Virginia, and it's actually a trial court case, and the only reason I bring that up is it's a very, very short opinion because it was essentially the court denied a motion to dismiss by the doctor to end the case early. So in this case, these are really all the facts we have. The defendant was a pathologist who reviewed slides of the plaintiff, and the pathologist then rendered a diagnostic opinion to the plaintiff's actual regular doctor. So those are all the facts we have, and looking at that, the court said they did not want to dismiss the case early, and they thought that there might be enough here to be fair to go to a jury to decide. So in Virginia, the court reviewed what the general test was for determining whether this physician-patient relationship existed, which is necessary necessary for a medical malpractice case. And the court said that the relationship must exist, and it can exist without any face-to-face contact, which is what happened here. The pathologist did not treat this patient face-to-face. The court uses this language that a doctor who assumes to act, who takes an affirmative act, even if gratuitously, may become subject to this duty. And that is how they applied it here to the pathologist. And based on these circumstances that this pathologist sort of took an undertaking to evaluate these patients' lives and to render this opinion, the court said, we're not going to dismiss it right now. This can go to a jury to determine whether or not this relationship existed. So again, it's possible the jury found that there wasn't, but looking at the circumstances, the court said it's possible that there is a duty. And the next case is out of Maryland, and in this particular case, a father sued doctors that treated his wife and the mother of his minor children, and ultimately the mother in this case died. And what happened here was a little interesting because at the time that this went to court, the defendant doctor did not remember this case at all, and there was a nurse practitioner who did remember the facts of this case. So there was a little bit of dispute as to what happened, but essentially this nurse practitioner gave a deposition in which she stated she remembered having this mother as her patient and that she called the defendant doctor to get advice as to what she should do, and the nurse practitioner stated she remembered the doctor giving her specific orders and directing a path as to how to treat this mother. Now, the doctor said he did not remember that phone call. He said he wasn't the on-call physician that day, and he doesn't believe that he did anything to direct this patient's treatment. Because the differing of opinions here, the court said what we mentioned, summary judgment earlier, which essentially means there is dispute in the facts. So the case couldn't be dismissed at the outset, basically because there was a dispute in the facts whether or not this phone call occurred, and if the phone call occurred, whether or not this doctor directed the nurse practitioner to provide certain care. So in this case, because the court said a jury could reasonably find from the fact that this doctor ordered a specific medication to be given to the mom and he ordered specific care to be given to the mom, it's possible that a jury could find that he did owe a duty of care and that a physician-patient relationship was established, even though he never saw the mom in person, even though he presumably never looked at her chart. They said there was enough here based on this testimony that he potentially faced orders. And I'm going to skip over this last case. It's out of Oregon, but essentially it's similar in that there was a phone call. This was within the hospital, so just very briefly, an ER doctor called a neuro doctor. And ultimately, this court said there's enough here for it to be a jury issue. It's possible that based on the phone call between the ER doctor and the neuro doctor that this doctor undertook to help the patient. And then I will turn it back to Adam, I believe. We've taken some of these cases and made a list of sort of do's and don'ts from the cases that can hopefully help lead to no duty of care being done.
So these are kind of an amalgamation of our review of all these cases. And again, getting back to the main idea I expressed earlier, the less contact you have with the patient and the more hypothetical questions presented to you, the more likely it is the court's going to say this is a very informal consult and the liability is going to attach. The problem is that, of course, the more informal it is, the less helpful you are to the person who's needing help. So there's kind of a tension here, I guess, between being helpful, providing advice, and being held liable for that. But in any event, the do-nots would be you're less likely to be held liable if you don't actually see the patient or examine the patient. That's probably the biggest thing. If you're not looking at the medical record yourself or making entries in the medical record, if you're not billing for your time, and if you're not asking for patient identifications, the patient's more anonymous, if you will. Speak in terms of hypotheticals. Give general direction as opposed to specific advice. This is probably the most awkward of all, but use disclaimer language. No, hey, I'm not really an official consult here. This is just a normal conversation only. But here's some things that you also want to consider. If you think the doctor is in over their head, maybe you should phrase that point in some way. If you think the patient really needs to be evaluated in a way that's not happening, probably should try to step in and see if that can happen. When we talked earlier about note-taking, this is just from, I guess, from an evidentiary standpoint, as a lawyer representing the hospital. It's always good, from the prior example that Annetta was talking about, it's always good to be able to actually recall what happened. If you say you don't remember and the other side says, well, I do remember, then the fact that you don't remember isn't going to contravene what they say happened. So if you can have something to latch on to, an email or some kind of note, to later establish the nature of the conversation, at least from an evidentiary standpoint in court of law, you're a little ahead of the game otherwise. And I think probably this is also useful we talked about that this morning in terms of maybe happening in departments, but trying to develop a consistent practice to handling these types of calls so that you can rely later on what you typically do as opposed to just what you can remember in a particular instance. So similar to what a surgeon might have a practice of disclosing risks of the procedure, and they know that they do it the same way every time, and therefore they may not remember the particular consenting process for a patient, but they can say what I always do is this. So that can also.
The reason there is that the law provides that as a professional, even if you don't have an independent recollection of something, you're allowed to testify as to your habit, custom, and practice. So it's an evidentiary rule that actually works in your favor, where you can't remember a specific thing. If you have a very routine, custom habit and practice of how you would deal with a certain situation, you're allowed to testify as to what that habit, custom, and practice is. And from an evidentiary standard, it won't be the same way as those who had a specific recollection point. Does that make sense? So that's why this is important. You testify. Yeah. Doesn't matter.
Well, yeah.
You would testify.
Getting back to what with some of the
You would
dues,
testify as to your habit, custom, and practice if it became an issue.
for example, consistently using disclaimer language when you talk to the other doctor. Again, it may be a little awkward, but if that's something that you do every time, then you can say, even if you don't remember the particular occasion, I do that. So it's just habits of, obviously each case is different. The advice you may be giving obviously is going to vary by patient, but the way you phrase what you're doing, you can develop habits about that. And those may help you in some way. So do you want to go to questions now?
Thank you all. Let's go through a few things. Returning to the newborn with mastitis, and this was a situation that came about after I had drafted our division's policy on curbside consults. My usual disclaimer language is I can't really comment specifically on this patient, but I can tell you generally for patients of this type. The problem with the newborn with mastitis was, I you really need to examine the patient. I can't refer them to a clinical practice guideline that's been, nationally vetted, or tell them to look in the Red Book. There just isn't sort of a good resource for that. Plus, the patient was now on vancomycin, which, as you know, is only given parenterally for these types of infections. So they're sort of painted into a hole. So I'm afraid I wasn't terribly helpful, and this is exactly the type of patient. I did offer, which is also part of my routine, that the patient could be transferred here and we could see the patient. I even went further in this case, and this was a nurse practitioner I had known from, she worked at Holy Cross, and I used to go there and do in-person consults with friends and colleagues. And so I offered to reproduce what we're now doing at Holy Cross, which is telemedicine consults. And I made a few phone calls and emails to the director of the NICU of this other hospital. They weren't buying it. Telemedicine may be one way around. So our policy at the moment, I'm happy to share it with anyone, and Becky was very helpful guiding us through how to develop this. We do want to be consistent, ask clarifying questions if we notice something being maybe left out. Be clear that it's hypothetical or general advice, some kind of disclaimer language, but I think I and some of my colleagues are not as diligent as we should be with that. I tell them, especially for our internal consults, I'm not going to look in the medical record. Don't tell me the medical record name or anything, medical record number, name, or anything identifying about the patient. And make clear that we're open for business. We can always see patients, and we can usually do it at very short notice. For people requesting it, it sounds sort of ludicrous, but make sure you know the story. And sometimes I see that most often when there's a change in shift, and the sign out was to call ID, and the person calling has never even seen the patient. So that becomes very difficult. I would say it's helpful to identify yourselves, because education is important to me, and it makes a difference what I say to a rotating adult ED resident or an attending physician, or, in terms of what I want to touch on. And the SBAR format, I believe, is very well suited to these kind of things, and you stayed up front in the situation part of it. Is this a formal consult, curbside, or maybe you're not sure? That's part of your question. And please have a clear question for me. If it's something that we're getting repeated calls on, or it's very involved, we may just have to bow out. We can't answer this over the phone or by email. People are always who don't know me, and they call me and they ask me again for my name and how to spell it. I know they're putting that in the patient's medical record, but don't do that, please. And again, if what the consultant is telling you doesn't make sense or isn't clear, request a formal consult. Although sometimes that's difficult with long distance issues. And with that, we've left a few minutes for questions anyway, try to distribute the microphone.
Becky, this is for you. Our malpractice is provided by the hospital. If I or Bud provide a informal consult to a community hospital, and then for another hospital, they implicate us. Are you all support us in that? We still are doing our duty as a physician of children.
We would certainly view that as part of your normal, activities as part of your job at Children's.
I don't think there would be a basis for us not.
Thanks, Shadi Ogunlesi. Thanks, Bud. This is excellent, and I think this session should have been mandatory especially for our trainees. As one person who's very much against this curbside consult, I'll read for you this is from the patient's chart that I saw yesterday for a consult that we were called for. This is an admission. It says, curbside pulmonary consult recommended, blah, blah, blah. POC notified. Please consult pulmonary on admission. Inpatient team not notified by pulmonary fellow. I think these are totally inappropriate, especially in terms of documentation. But I stand to be corrected if that's a legal thing or not. But I think also that many of us have gone to bedside consults where I have refused a curbside consult and asked specifically, do you want me to do a consult? And you find that the question is actually totally different, or your consultation reveals that your intervention is different from what was being asked. One of the things that many of us have looked into for medical education is how to frame consult questions, which is another issue that our trainees have to learn. So I think this is a very important topic that needs either further, dissemination, or especially for our trainees. I know people are trying to get, timely consults and get patients out discharged on time because Dr. O would not see the patient till 3 o'clock in the afternoon. There are many reasons why people get to these curbside consults, but we need to focus on them and see which ones are appropriate. And thank you for all those the lists that you provided, because I think we should all adopt some of them.
Thank you, Shade. Andrew.
So one area that I find this comes up a lot and would appreciate some advice on is for the NICUs that are part of our hospital's network, in the surrounding areas. So we get, I think, somewhat conflicting advice around how to deal with those, where there are physicians who are neonatologists, and we get called a lot for advice, and there is, appropriately, they want to keep the patients in the local NICUs, but we don't access those records. It's very different, as we've heard, getting kind of the phone consultation, and I am positive that they are documenting, spoke to endocrinology, spoke to cardiology, spoke to whoever, and these are their recommendations. So again, these are the competing balance. Like, that specific issue, I would appreciate some guidance as the consultants, specifically the NICUs that we own.
Well, let me tell you first my understanding, and then I'll get corrected. But there is no difference in curbsides, whether it's part of our health system or not, or even just downstairs in the ED here. So curbsides are all the same, whether they're part of us or not. But as you say, once you go in the chart and start doing stuff, then it gets a little hazy. We in ID are very much trying to expand our telemedicine, especially to NICUs. And we've been in preliminary talks with our affiliated NICUs about setting up telemedicine consults in some of our other areas. I've had great experiences doing this with Holy Cross NICU. We can expand that.
I think that's a great suggestion. I almost think that if the hospital could systematize for all the NICUs that we staff and networks, that we just have standard centralized telemedicine access to all of those NICUs, that would be great. We'd be happy to do consults though. I don't know how the other chiefs feel.
All right, maybe one last question from Dr. Wells.
This This is great. I love how you address external consults and the internal. For a few years now, neurology really tries to avoid curbside consults, both in requesting and delivering. And I don't know if we're more conservative than others, but it's really served us well.
Well, and I think, Beth, from the neurology standpoint, and this applies to telemedicine too, where intricacies of the exam become so important. And, one examiner's, general pediatrician's neurologic exam is very different from yours. So that can get dicey.
That's a great point. And and increasingly, as people want us to look at videos, we're trying to understand how to incorporate that officially, especially overnight.
Yeah. All right. Thank you all very much. And please, anyone contact me if I can be of any service.